Marcin, a little European flair. I appreciate it. Okay, officially it is 9:30, so we're going to start and we're going to talk about pneumonia and RSV, which are exemplars for the concept of gas exchange. How many of you have taken care of a patient with pneumonia already in clinical? I got one. I've got a couple of yeses. 'Tis the season. Alexandra has many. Your care plan should be stellar then. And we're going to go over some interventions today for a patient with pneumonia and all of the different, treatment and that kind of stuff. Okay. So I'm not going to go over this. We went over this last semester, but this is the concept for gas exchange. And we're going to travel around to talk about the interrelated items, negative outcomes that we're going to try to prevent or bring our patient back from, and go towards those positive outcomes and the ideal optimal conditions that are there in the purple on the left. And there are a lot of sub concepts, and we're going to talk about those during the case study today. Before I really start, I want to bring up two things. One is I only have an hour, which I'm stressed about. So I'm going to break for questions at the end. I just want to make sure I get through all of the information. The other thing is, if you've come to simulation for the med-surg post-op simulation, not the OB one, but the med-surg one, I forgot to tell some of the groups about the SurveyMonkey evaluation. Check your messages in the course or your email, because I sent you a message with the link. So I would really appreciate it if you completed those evaluations, because it helps me with further simulations, plan further simulations, and whether or not simulation is important. Okay, end of that commercial. Okay, so pneumonia. It is the 8th leading cause of death in the United States, and it's pretty significant. Especially for our older people for a variety of reasons, and we can talk a lot about comorbidities, but it is the leading cause of death from infectious disease, and 3% of adult hospital admissions in the United States are related to pneumonia. The real, not problem, but pneumonia can be prevented by vaccination. And pneumonia is the most mortality that can be prevented by a vaccine. And it's influenza and pneumococcal disease. So it is very prevalent, but it can be prevented by making sure that our clients are, children and adults are vaccinated for pneumonia. So let's talk a little bit, and I'm going to make you go back to anatomy and physiology. What are some of the defense mechanisms that we have in our body to help prevent pneumonia? So put them in the chat. And there's a bunch. Besides immunizations, white blood cell counts. Yeah, your white blood cells are going to go and fight antibodies. Coughing, excellent. Cilia, I saw. I'm not sure skin is related to pneumonia, Ryan. It's absolutely a defense mechanism to infection. What about some of the risk factors for those of you that have taken care of patients with pneumonia? What are some of the pre-existing conditions or other risk factors that may put your patient at risk for? So we've got smoking, vaping, Aspirating, which you know from last semester, absolutely. Immobility, excellent. Keep going. You're doing my job for me. Asthma, absolutely, Stephanie. But wait, there's more. COPD, absolutely. Age, we know with our patients as they get older, and also think about the very young. Right now, I've got a friend of mine who's little, I think she's 3, is in the hospital with pneumonia. And there's a lot, and we're going to talk about that in RSV, but there's, age things like, exposure to disease and those kinds of things. Those who are immunocompromised, absolutely. There's a couple of more. Can anybody think about what was not mentioned? Um, I, I don't have allergies, Marcin, but I'm kind of thinking that maybe if you have significant allergies and have that inflammatory response, maybe, but it wouldn't be on my top list. But I just rationalized it. Okay, let's see how you did. So the defense mechanisms that you mentioned, um, also consider the size of the airway. So our small children, their airways are really small, very difficult to cough in, and also any of you have 2 and 3-year-olds and try to get them to expectorate mucus or have them blow their nose. Good luck with that. They run away. um and also to get them to cough, right? So we can have our clients do deep breathing and coughing and get them to mobilize. The nice thing about children is once they start to feel a little bit better, they'll get up and run around. But to try to get them to cough and to do deep breathing is a challenge. Again, my friend whose daughter's at CCMC right now with pneumonia, they're doing bubbles, which I'm sorry is way better than incentive spirometry. Spirometry looks lame compared to bubbles. Um, but also, you want to make sure that you're not creating a slip and slide in the patient's room. And cough, ability to cough, strength of cough, all of that is important. And I did see somebody mention immunizations. Again, really important. Recommended for different age groups, those with chronic diseases like heart conditions, lung disease, alcoholism, diabetes, cirrhosis, renal failure, those who are immunocompromised, and don't forget organ transplantation, because they do have a degree of being immunocompromised. Age is important because, as you know, the number of cilia decrease, the gag and cough reflex can be diminished, and also a risk for dehydration. Are very young are dependent on us for fluids, right? And also those that are older, and especially we've had conversations about, people with dementia forgetting to drink, those kinds of things. As we age, what is the immune function of the patient, the medications that they take, and we talked about comorbidities. We're concerned, and somebody put about aspiration, concerned about the cough reflex. Um, and I did not see smoking on the list from people here. So you know that smoking damages airway tissue and decreases the number of cilia and the cilia function. So, and it clogs up the cilia, it just makes a big mess. The chemicals in cigarettes also numb the cough reflex. So we want our patients to cough, and then we're a little set up to be, not as effective. Okay, excellent. Thank you. Okay, so the offenders, a lot of the pneumonia that we take care of is hospital required. And there's a couple of organisms here that, if you recall from microbiology, which I'm honest with you, I really don't. But a lot of them are community required. So that goes back to hand washing, staying away from people that are sick. Those kinds of things we know, and we should be continuing to teach our patients, right? In hospital acquired, it's usually a different organism. And we would prefer, we don't want our patients to get um, a hospital acquired pneumonia. And going back to aspiration, um, how we're are we isolating a patient, those kinds of things. You do not need to know the organisms for the exam. Stephen, you asked about certain occupations as far as exposure to pneumonia or respiratory. I would say exposure to respiratory disease. I'm sorry, irritants could make you more susceptible to pneumonia. So I'm going to put my environmental health nurse hat on, which, so if you think about somebody who should be wearing PPE like a respirator, or somebody who at a hobby is, say, spray painting a car and not wearing any kind of protection, or somebody who is sanding and inhaling even just wood dust, those are
Right.
going to be irritants that are going to cause an inflammatory response. And then if the patient's exposed to some organisms, it could definitely set them up to pneumonia.
Like those
Thank
working with asbestos and
you.
insulation and stuff like that. Shipyards.
Okay, so I love to look at x-rays. I'm terrible at reading them, but I thought that I would show you these. And you can see here that on the left is a normal x-ray, and the one on the right-hand side has a right middle lobe consolidation. And it is this patchiness that's here that shows the consolidation is the word that they use for with pneumonia, that it's just kind of like sucked in with secretions and fluid and organisms and general pneumonia nastiness. Take the opportunities that you can when you're in clinical. If people are looking at x-rays, ask them if they'll show you or explain them to you. Again, there's no expectation in our job that we should be able to read x-rays. I just find them fascinating. I share the joy. Here's another X-ray that I find interesting, which is a pleural effusion, which is an accumulation of excess fluid in the pleural cavity. And this accumulation can lead to a significant infection because, as you know, anytime we have stagnant fluid, um, germs will tend to settle in there. You've got uh, darkness, you've got glucose, so you've got a feeding source, and so you can have pneumonia. And they may put a tube in to drain it. Has anybody seen a thoracentesis? Another really cool thing where they put a tube into, Julianne has seen it. They put a tube into the chest cavity and this fluid comes out. Often, most of the time, I'm going to say it's attached to a suction drainage device, which I know is a pleurovac. There's probably other fancy words for it.
I
But,
saw one
and so
that's
then
clinical.
it'll drain. Very cool. Okay, so the symptomatology that we're going to be looking for, or we may see in a client with bacterial pneumonia, shaking chills, fever, sometimes a really high fever. My little friend's daughter, 103 point something. Breath sounds. As you go back to that x-ray and think about what you're going to hear over that consolidation. Not much. There's not real estate for gas exchange because it's all plugged up with the consolidation, the fluid, the congestion related to pneumonia. You can also hear fine crackles or rails, which is, again, the fluid. You can have cough, and you can see either rust-colored or purulent, like you can see green sputum. The rust-colored can be because of the irritation of the pneumonia and the coughing and the secretions, that it's actually blood tinged. The client can have pleuritic pain, and the pleuritic pain is sharp localized chest pain that increases with coughing and breathing. And it is a lot of irritation, so that you can have just imagine it hurting so much when you cough that you don't want to cough, but yet That's what everybody's telling you to do that you need to do to get better. So I would suggest that pain management is incredibly important. Dyspnea, so difficulty breathing, painful breathing. Again, the pleuritic pain is going to play a role. Hypoxemia, a low O2 sat. Again, my friend's daughter in the 80s. Thank you very much. A little scary. Um, Cyanosis, which is a very late sign, and confusion and agitation, which might be an earlier sign. Sandy, did you have a question?
Yeah, I was just gonna ask if you're giving somebody like something for pain management that they
Okay.
typically take,
So,
or maybe
again,
something new.
pediatric considerations. Um, Children can become more high. You can, I'll get to that in 1 second, Catherine, Aaron. Um, Pediatric considerations. Children can become hypoxic more quickly. And it really does talk about children have more compensatory mechanisms, and then all of a sudden they just stop. They can't compensate anymore and they can get hypoxic really quick. You're going to see the tachypnea, and that's why knowing the different respiratory rates for the different age groups is so important, because a baby is 40 to 60. My friend's 3 to 4 year old, she snapped a picture of the monitor, so of course I had to look at it. And she was breathing in the 40s. And a 3 and 4 year old shouldn't be breathing in the 40s. Breath sounds, again, all of those adventitious breath sounds that you're going to hear, nasal flaring, you're going to see increased work of breathing. You can see retractions, you can see substernal retractions, you can see pain, nausea, vomiting, diarrhea, and you can see apnea. So again, Aaron, I'm going to address your question about decreased appetite. For many reasons, adults and children may not have a great appetite. First of all, how hungry are you when you have a fever? Probably not very, right? And then this increased work of breathing. Think about when you have a cold and you're trying to drink, and it's so much of a challenge, right? That you can't breathe and drink at the same time, or you kind of suck it up and you drink, and then you're gasping for your breath because you can't breathe. Well, that's one of the issues with children, is that it's so hard for them, and trying to get them to breathe, to figure out that mechanism that we can do as an adult, they can't do. And they're also dependent on us for fluids. So, and then also think of their body surface area, they can lose more fluid. So they're kind of set up to be a little bit more dehydrated more easily than adults. So we really need to be careful, and IV fluids would be a significant consideration if the child can't take in enough fluid. How would we assess an adult or child for dehydration, somebody who's coming in with pneumonia? Weight is a good way to assess, but to be honest with you, if a child just came in, nobody knows what the child's weight is, right? And different scales and those kinds of things. So the weight difference isn't going to help us. Skin turgor, absolutely. Capillary refill, looking at the mucous membranes, which could be incredibly dry. Um, Cracked lips. Um, I see labs here and I agree with those, but there's things that we can do with our eyeballs that we can tell right away. And you can see eyes sunken. Yep. Thank you, Nicole. Urine output. So what does the urine look like? Is it dark yellow? When was the last time they voided? What if it was 12 hours ago? You can also do a specific gravity, and there are ways to get that result immediately. But we know that you can tell, like if they haven't voided in 12 hours, they're probably dehydrated, right? Or if they voided and it's a very small amount and it's really dark urine, again, dehydrated. Talking to the parent about how much they've had to drink, absolutely. Keep in mind, if we're trying to encourage that, what we want to find out about likes and dislikes, and we should be doing that for our grown-ups too. Fontanelle sunken, yes, that's a great way to assess for hydration. But keep in mind the fontanelles start to close, and they may not be, I'm going to say available, but prominent. You might not be able to assess them if they've closed. Okay, so also there's viral pneumonia, which is 10% of pneumonias in adults. And most of the time it's influenza and adenovirus. And we know that the symptoms are usually more mild than bacterial, and it's more flu-like with headache, fever, fatigue, malaise, muscle ache, and dry cough. What we don't want is our patient to get sicker. So diagnostic testing, you like my CAT scan? We're going to do a chest x-ray and a CAT scan. And they're going to do a sputum culture and sensitivity. What I want you to know about getting a sputum culture. A sputum culture can be really important, and we want to make sure that we get enough. So the best way to get a sputum culture, if you can, is to do it first thing in the morning. Hopefully your patient has slept. There's more secretions. And so what you want them to do is to take a deep breath, do a huff cough, which literally is a huff cough, and it opens up the airway, and then have them cough and expectorate into a sterile container, and that would go to the lab. Okay, so again, sterile container, best time would to do it in the morning unless they have copious secretions, and you can get it anytime. Okay. A CBC, which was mentioned because we're looking at the white blood cell count and all of those different things. Serology testing, O2 sat, ABGs, and ABGs, your patient's got to be pretty sick to get ABGs, because ABGs are kind of crummy. They hurt. They're going into an artery, usually in the wrist, very uncomfortable for the patient. And then they might do a fiber optic bronchoscopy to see if there's something in the lungs that's causing the pneumonia. Does anybody know what one of the big culprits with pneumonia for children is? And they would do a fiber optic bronchoscopy. Oh, corn kernel was not going there, Nicole, but that's interesting. And you're in the right neighborhood, Nicole. On what, Alexandria? Not grapes. Not milk. Aspirating what? Not a tooth? Not a hot dog? Oh, Alexandria is going the big concept, food. It's peanuts. That little sucker will slide right down into the lungs, and it has to do with the protein, and I don't want to get into it, but it has to do with the protein. And when it gets into the lungs are really unhappy, and this whole thing happens, and it makes just a big mess in the lungs, and as far as infection and consolidation, and they have to go in with a bronchoscopy to extract the peanut. Let me see. Okay. Good. Thank you. Okay, so what interventions should we have in place for our patient? We've already talked about some. Well, yes, Alexandra, we should be very careful about giving children peanuts. All right, so what interventions? We talked about some of them. Make me proud. So absolutely, positioning with eating, preventing aspiration, mobility, spirometry. But wait, there's more. coughing, deep breathing. I'm about to get bubbles for everybody. Medications as ordered by the provider. Oh, fluid intake. I was waiting for that. Thank you, Lorraine. Yeah, we really want to encourage fluids as much as we can. For an adult, it might be like 2,500 to 3 liters a day. Again, we've got to think about our patient, whether or not they can tolerate all of that, but it helps with the fever and it also helps keep the secretions thin, which is really key. We need those secretions thin so that when the patient coughs, it's easier to expectorate. If those secretions are thin, how are they going to mobilize them to expectorate them? And another thing to add to that, when somebody had asked a question about eating and hunger and that kind of thing, one of the things that you try to do is have your patient again expectorate the secretions. Good luck with children trying to get that done because they end up swallowing it, and then they can have some gastric distress, and they end up with diarrhea because the GI tract does not tolerate those secretions. And it's not that big a deal. It's not like terrible diarrhea. It's just mucus diarrhea that occurs. Okay, I see antipyretics, vital signs. Okay, let's see how you did. So fluids we've talked about, IVPO. Activity, I saw walking, ambulation, changing the patient's position, medications, oxygen. Again, it's a provider's order. We need to collaborate with the provider about what the patient may need, whether if they're improving, can we decrease it? All of those vital signs, so important in sinus spirometry and bubbles. Comfort measures, things like positioning, making sure what can we do to get our patient temperature under control. If they're diaphoretic, changing their bed linens, those anything we can do to get them comfortable. Smoking and alcohol. Alcohol depresses your cough. There's dietary concerns as well. We've already talked about smoking. And then postural drainage, which is this picture that's here on the right-hand side. Has anybody seen postural drainage in the clinical area? I got one no. The rest of you have been absent. Okay, so postural drainage is one of the things that respiratory therapy does that it's a clapping sound, and I'm going to totally date myself. How many of you have seen Monty Python with the coconuts and the horse galloping? I got one yes. Thank you for not making me feel lame. Yes, it is percussing on not just the back, but it's all the lobes. And so what you want to think about is how does the lobe of the lung empty into the bronchus, which is why there's all of these different positions. So that if you start at the top where the person is in the chair or in the bed, those upper lobes empty down by gravity, right? So that the respiratory therapist would clap, and it's you cup your hands and you get that horse sound, that galloping, which causes a vibration in the lungs to help loosen secretions. And then the patient, as you can see, is going to change positions all the way around here. And you can see where it's related to how they empty into the bronchus to loosen the secretions, to promote coughing, and then expectoration of the secretions. There's also vibratory machines that respiratory therapy might use. And I also had a friend of mine who has cystic fibrosis, and there was actually a vest his mom would put on him. I can't speak to Asian massage, but I would not be going to Asian massage for postural drainage. But no, you do not need to know. All I want you to know is postural drainage helps loosen secretions. That's all I want. Okay. Let me see what else. I just want to make sure. Okay. So we talked about fluids and we talked about keeping secretions thin. We talked about the importance of activity. We want to make sure that we pace the activity. We don't overdo with the patient. And when we're walking with them, I would suggest doing an O2 sat as they walk so that we can make sure that their sat isn't decreasing and we're not overtaxing them. Positioning to promote airway clearance. Having the patient upright for eating, but also the changing position to mobilize secretions. Some of the medications you may see are mucolytics, which promotes expectoration of secretions. It breaks up mucus, or bronchodilators, which opens up the airway. Things like, Ventolin. Okay. Really quick review, and I'm going to spend 10 seconds. So different delivery devices that know that the highest is that non-rebreather. So medications, one of the first ones, and we started the day with this, talking about the vaccines, that they're so important. And looking at the different vaccines, you've got the Prevnar and the numbers and all of that. And I didn't really realize that the Prevnar 13 or the 23, those are the different number of organisms that cause pneumonia that vaccine covers, which I thought was kind of cool. I learned something new. So contraindications, severe allergic reactions to the immunization, or the DTaP, the diphtheria toxoid vaccine. Again, I learned something new. And if, again, they have moderate or severe illness. And we talked about this last week when we talked about the other vaccines. It's got to be pretty severe illness not to get vaccinated. So a cold symptomatology, the provider is going to say, let's still get you vaccinated. The vaccine should be given to those with comorbidities, including diabetes, smoking, alcoholism, if you're immunocompromised, HIV, cancer. Again, it's a conversation with the client and the provider. Side effects, not too many. Injection site pain, swelling, erythema, fatigue, myalgia, arthralgia, the achiness, the joint pain, and headache. Other medications given for pneumonia, antibiotics, things like amoxicillin, TMP, SMZ, which I know is Bactrim. Penicillin is more, as you know, a broad spectrum antibiotic. And then you've got all the different generations of cephalosporins. I'm dating myself because I remember when they were new. So what they've done through the different generations is they've developed further spectrum, that they cover more organisms and they have more increased effectiveness on some of the organisms that have developed resistance. The adverse reactions to cephalosporins are rash, fever, which can develop a few days after the start of therapy. I'm sure some of you may have heard of a friend whose child or they've started an antibiotic and it's day 4 or 5 and now they have a rash and they're not, is it the antibiotic? But I've been on it for a few days. They need to consult with their provider. Cephalosporins are contraindicated with severe penicillin allergy. Again, a conversation with the provider, then it may be given if they're unable to take penicillin. The early generations, the first cephalosporins that were made, there were specific concerns about kidney toxicity, but that has been resolving with later generations. I'm going to skip this because I'm a little concerned about time, but we may come back to it. Because we're going to talk about these are just what I did was I took the concept and then put the defining attributes. So we want effective, our goals, we want effective ventilation, right? We want our patient to breathe well. And we talked about choking and those kinds of things. We want effective oxygen and carbon dioxide transport. We want good tissue perfusion. So these are the things that we're going to be assessing for. And these are all on the concept card. These are also all on the concept cards. Okay. So who are we going to collaborate with? Interprofessional collaboration. Respiratory therapy, the doctor. Who else? But wait, there's more. Physical therapy. I'm not sure physical therapy. I think that would be an individual consideration, especially if our patient needs adaptive equipment. Infectious disease, absolutely. I gotta put that on my list. It's not on my list. Nutrition, family members, speech therapy for dysphagia. So did pretty good. Don't forget social services, and don't forget planning for discharge and the visiting nurses. And I'm putting ID on my slide. Thank you very much for that. Somebody had that on there. Okay. I did talk to Margaret Guerrero, one of our respiratory therapists, and I said, what do you want the students to know about pneumonia and all of these? And she said, please emphasize that it's contaminated hands that spread bacteria from infected patients and contaminated surfaces, and that putting on a pair of gloves without washing your hands may protect you, but it doesn't protect the patient. So again, hand washing and looking at those, what causes hospital-acquired pneumonia? And she also said that to make sure that you understand how hospital-acquired pneumonia can become deadly when it results in sepsis, which you know, we don't want our patients to get sicker because they're in our care. So she also wanted to make sure that people really, if you look at your hospital beds and look at the angles, when we're talking about the head of the bed being elevated, where should it be? And is that truly where our patient is? You know, have they done the slide down, or is the head of the bed not elevated where it should be? So that is the end of my commercial from respiratory therapy. Okay, so we're going to transition to RSV, which is a virus that all of us can get, but it is very dangerous to children for a lot of reasons, which we're going to talk about. It is highly contagious. And, you know, all of us have it. But the danger is when we can spread it to a child for many reasons, which we're going to talk about. It is the leading cause of acute bronchiolitis. So there's a test now for RSV. And before, we used to just call it, oh, the child has bronchiolitis, but now we get to know that it's viral. The peak season is late fall to early spring. Yet that is a little off now because of COVID, where children haven't been really out of the house. And so now they're being exposed so much. And we really don't get an immunity, so you can get RSV more than once. It is spread by direct contact with respiratory secretions. It's a droplet infection or an infected individual, organism evading the body through the eyes, the nose, and the mouth. So those mucousy kind of organs. And so the cells get infected and then they burst and die. And the debris clogs the small airways of the lower respiratory tract, irritating the airway, resulting in edema, which is your bronchiolitis. And you have tons, and I'm going to say tons again, mucosal secretions. And you can get partial airway obstruction, some from the inflammation and some from these copious secretions. So you can get wheezing and you can get bronchospasm and you can get a really horrendous cough. Adults can get it as well. the issue with children, and I'm going to go back to what we talked about a little while ago, is children are more at risk because their airway is small. So if they have all of these secretions, their airway can become blocked. You also have issues with dehydration and not eating and not drinking, and then the fever and them getting so sick. So, okay. So diagnostic testing, similar with pneumonia, chest x-ray, um, assessment, listening to lung sounds, vital signs. Um, we want to know how long the child has been sick. Is any, does the child go to daycare? Is there anybody sick at daycare? Is there anybody sick at home? Fluid status. Again, with this really horrendous cough, the children can get a sore throat. Our adults can too, but we can manage that with maybe thinking about what works, like cold fluids, or making sure that they're medicated with Tylenol. And we have to consider that with a child. It's just difficult to assess for that, especially if they have limited verbal skills. Vital signs, O2 sat is important. Breath sounds, listening for those adventitious breath sounds, a runny nose, and again, I'm going to go with copious secretions. And again, trying to get a 2-3 or yet younger to blow their nose to clear those secretions is a challenge. I'm going to talk about the weight in a second. So interventions, fluid, IV and PO, we need to assess that fluid balance. Vital signs with O2 sats, and we need to make sure that if the child needs supplemental oxygen, which can be a very significant challenge with a small child trying to keep a mask on. And it's almost it's a terrible sign when you put a mask on or nasal cannula and they just leave it alone. When they start to get unhappy about it and trying to rub it off, you're like, oh, they look a little better. Antipyretics and maintaining the airway. Suctioning is a challenge because you don't want to set up more of an inflammatory response with suctioning, and you can do that. And it is more upper airway. So deep suctioning, first of all, is a learned skill, respiratory therapy, and you can cause bronchospasm and a lot of other issues if you don't know what you're doing. But using a bulb syringe like here and getting secretions out of the mouth and then nose, if you see secretions, can be helpful. What we tell parents is if you don't see anything, then there isn't anything to suction. So putting that bulb syringe into the nose can set up more inflammation, and now there's more restriction of airflow. And for contamination, it's a little contrary to my thought process, but you do the mouth first, then the nose, because they feel the nose is more contaminated. We should be sending all of our new moms home from OB with the bulb syringe that's in the crib, with specific instructions on how to use it. Again, suctioning for secretions that you don't see is not effective at all. Your book talked about, so sorry, there was a comment somewhere about using high normal saline therapy. And I did a lit search and, oh, I'm sorry, nebulized hypertonic saline. So it's high saline. I think I saw 2% and 3% versus the 0.9 that we do. And I talked again with respiratory therapy, and I did a lit search, and I found this study from Morikawa, and it said it really didn't work very well. It didn't reduce the length of stay. And in talking with Margaret of our respiratory therapy department, she said that it was linked with bronchospasm and other issues, so that it kind of set you up for further problems. And again, in my pediatric experience, I never saw the nebulized hypertonic saline being used. And I would leave that to the professional respiratory therapists. So let's talk about retractions. So in children, these are some ways that you could see them visible. So you can see the substernal, actually the whole flippin' airway here retracting with this child trying to breathe. And I look at this poor little bubby's face here, and I see the effort of them trying to breathe. And I'm not sure, but I'm thinking I see a little cyanosis up here. I'm not happy. I'm a little concerned. And also a dry diaper. And the mucous membranes do not look moist. See how you can do this in a second? In this picture over here, you can see the intercostal retractions. You can see the work of breathing so much that the lungs are trying to expand and they can't, and that there's going to be retractions in between the ribs in an effort to get more breathing, more air exchange. Pretty significant. I don't like that. So here's another x-ray with RSV. Okay, so what patient teaching would we include? We're going to talk about parents. Importance of fluids, absolutely. Hand washing, always. Avoiding secondhand smoke, absolutely. Well, we want to kiss the baby, but we want to make sure that we don't let them near anybody sick. How to clear the oral and nasal passages with a bulb syringe. Also, when. Positioning in bed, daycare choices. There's more. All right, let's see how you did. What to notify for. So we always want to have teachable moments. Wheezing, trouble breathing, high fever, anything over 100.4, they should call. Let the provider talk to the parent and make an assessment over whether or not the child needs to be seen. Any kind of discoloration of mucus, yellow, green, gray, that red tinge, right? Clear, white, we're pretty happy with that. Thick nasal discharge, which is really speaking about the child's hydration status and also a concern about obstruction of the airway, might be next. Poor oral intake, signs of dehydration that we've talked about, signs of cyanosis, a baby being irritable, crying, not being able to console them, excessive coughing, which is going to lead to poor oral intake, wheezing, retractions, flaring, rapid respiratory rate. And again, that's going to change based on the child's age. Listlessness. Oh, dear God, periods without breathing. Scares me now. So pediatric considerations for a child in the hospital. What do you see in this bed? We're just gonna talk about it because I'm looking at the time. So I look at this and I see stimulation. I see comfort for the child. I see age appropriate toys. Um, um, I see like a little nest for the baby. So this is a baby. This baby looks like 3 months old, maybe. So not turning. I see positioning where the head of the bed is up a little bit. I see protection on the baby's face for the oxygen tubing. Okay. I see protection for the IV. So if you look at the baby's right arm, the IV's there, but there's an arm board to protect the IV. Oh, Bubby. Because this is what we want. We want a baby at the end to be happy. Look at the protection, the little circles on his cheeks. That was for the nasal cannula so that it didn't press on the baby's cheeks. But you've got this baby's color is good. He's smiling. His eyes look amazing. And he's happy with his mommy or daddy or maybe the nurse. Maybe he's happy with the nurse. Okay. So let's talk a little bit about NCLEX alternate format questions. So, how many of you have heard about the test is going to change and there's going to be new style questions? I hope so, because I know I've mentioned it. Okay. So, right now we're going to talk about three different types and we're going to go through them related to bronchiolitis. So, this is an example of a case study that you may have as part of your NCLEX test. So, a 10-week-old is brought to the emergency room with 3 days of rhinorrhea, congestion, and cough. The mom feels that the infant is in need of help breathing and states unable to breastfeed all day. Consider breathing and breastfeeding. If you're stuffy in the nose, you can't do it, right? So the baby's exclusively breastfed. So a challenge for INO. The older sibling is at home with respiratory illness as well. So we've kind of already talked about that. Is anybody else sick at home? So here's the assessment for the baby. They're giving you this information. The temp is 99.2. The heart rate is 178. Respiration 65. Sat 92 on room air. No known allergies. Born at 39 weeks. Up to date on vaccines. In the assessment, mild intercostal retractions, restless head bobbing, intermittent wheezing in both lungs, congested cough, unable, unable to stay latched to the breast, capillary refill is 4 seconds, and the extremity pulses are 2+, and parents are at the bedside. So question one, hopefully, okay, I did it right. The question is going to ask you to highlight or place a check mark next to the assessment findings that require follow up by the nurse. So, of all of this information that they gave you, what is concerning and what needs follow up by the nurse? So, this is an example of a question that they're going to ask you on NCLEX. I see the O2 set. I see the cap refill, heart rate, retractions, wheezing, head bobbing, no latch, unable to stay latched. Okay. Let's see how you did. Oh, shoot. I'm so sorry because I had the answers highlighted and I screwed it up. Okay. The heart rate of 178, higher than normal. The respiration 65, higher than within normal limits. That's why it's so important to know you're within normal limits. The 92% on room air is also concerning. Again, the temp isn't high as 99.2. Baby born at at 39 weeks, okay. If it was premature, different story. Up to date on vaccines is normal findings. The concerning things about the physical assessment, retractions. The restless head bobbing is kind of a normal finding and it's okay. Listless would be a problem. Intermittent wheezing, a problem. Congested cough, they're saying that it doesn't require follow-up. I'd like to see the secretions. Unable to stay latched at the breast, yes. Cap refill concerning, normals 2 to 3 seconds. This is 4. Okay, excellent. You are ready. Okay, next question. I forgot what this one's called. The first one was an enhanced hotspot, they're going to call it. And this one is called a cloze, CLOZE. So what you do is you take the information for this, for number one, and you would put them here. And then you're going to finish the phrase with options for number two. So based on the infant's assessment data, the nurse determines that the infant's abnormal vital signs are mostly due to. So there's three things. There's one you're going to omit. What would you omit for number 1? Yeah, probably hunger. Okay. So for number 2, okay, the priority action is oxygenation and nasal clearing. Nursing actions for nasal airway clearing include. So which one of these 4 would you omit? Nasal suctioning, oxygen via nasal cannula, normal saline, deep suctioning. Which one would you omit? Because we can't do it any other way. So we would omit the deep suctioning. We're going to do the nasal suctioning like we talked about. We're going to do oxygen via nasal cannula, and we're going to do normal saline for suctioning if needed. Again, we should have a provider's order for that. And here I put the answers in. Okay, here is the last one. And this is going to be an extended multiple response. So, you know, the select all that apply. So this is going to be a lot of select all that apply. And for what they're saying is that you're going to get partial credit for every one that you pick. Okay. So the infant is treated in the emergency room with nasal cannula and blow by suction. Albuterol is given, which is a bronchodilator with no effect for the wheezing. Ordered a chest x-ray. The baby improves slightly with decreased respiratory rate, but still has significant nasal congestion. Rapid laboratory testing for RSV is pending with a probable diagnosis of bronchiolitis. The infant is admitted for ongoing care. So, which of the following complications would the nurse anticipate? So, what are you going to be looking for this baby? What are some concerns? So, if we can anticipate what might happen, we're going to put measures into place so they don't occur. And these are the things that you would be picking. Oh, cheapers. Okay. I messed up. So sorry. Respiratory failure, dehydration, fatigue. The baby is just going to get tired of breathing. And hypoxemia and apnea. Not pulmonary edema, not vomiting, though vomiting might happen if they swallow too much of those secretions, but it's not going to be a lot of vomiting and not being too concerned about vomiting being a problem. But we are concerned about dehydration, respiratory failure, fatigue, hypoxemia, and apnea. Again, they might vomit from the secretions, but it's not going to be like a gastro kind of vomiting. I don't know why not infection. I'm kind of struggling with that too. But that's what they said. All right, everybody. It is 10:28. Professor Chalal will be here in a few minutes. And if you have any questions, please shoot me an email. I'm more than happy to meet with anybody. Thank you. You too. It's going to be nice out today. Good morning, Professor Shalal. I just finished with them like 2 minutes ago.
Okay, sounds good. So we'll have probably a break, 5 minutes break or so, and then we can start, right? Can you hear me, everyone? I just want to make sure. Okay, okay.
Yes.
Okay, perfect, guys. And since you just finished, and we'll take a break, 5 minute break, and at 10:35 we will start. Hi, everyone. So it's 10:35. So we'll start with our discussion, and I hope you all are doing well. And I'm seeing in the chat a message that the anything in dark in the PowerPoint, it's not printing well. And as I can see, Stephanie is totally right. As I can already see that in the PowerPoint, I'm not even able to see the letters and my name that was there. So I just want to let you know, I will change the theme of the PowerPoint and I will repost it because I know many of you like to print it and then read it. Yeah. So I'll change the theme and I'll make sure I never use this theme again. I guess it's not very good. This was the first time that I used it. Okay, for some of you it did print well, but anyways, I will change. I will just change the themes again. I'm not gonna change anything written on it. Yeah, looks nice. NFI Lexus, right? Basically, it's a big mess. So that's how it's going to look probably. and so, okay. So we'll start with our discussion on NFI Lexus. Before we do that, actually, I just want to let you know that in the lecture on hypothermia, there was a correction. There was a discrepancy in the temperature. Um, the temperature at which we have to do the rewarming for the patient with hypothermia. In one PowerPoint, one slide, it said 2 to 5 degrees Celsius. On a second one, it says 2 to 5 degree Fahrenheit. So it's 2 to 5 degrees Celsius. Okay, I just want to make sure a couple of students reached out to me with that. And so the rewarming temperature is 2 to 5 degrees Celsius. I still have to correct it. And after the lecture, I'm going to work on that. And the second correction was in otitis media under the lecture the infection. So otitis media, antihistamines and decongestants are not helpful in otitis media. Okay. In the book, it mentioned not helpful, but in the PowerPoint, I put it is helpful. So I apologize, but that's a correction there. Okay. And few students reached out to me. Obviously, there was no question, so I didn't want to confuse it. I didn't post any announcement or anything. And but moving forward. You can correct it. I will correct it in the PowerPoint as well. So antihistamines and decongestants are not helpful in otitis media. Okay, it's just the antibiotics and the surgical treatment as we discussed. Okay, so having said that, we'll start today's discussion on anaphylaxis. And so anaphylaxis, I'm sure you have heard of the terminology, you have a little bit background on it. It's as it is, it's not a very big lecture. It's a relatively smaller lecture with not too much content on it. To provide, first of all, you a little bit background on your readings. So anaphylaxis, there is not much in the book, first of all. So don't try to find it as I did, literally scrolling through, every page and your 2 volumes. But there is not much information. In the pre-reading, in the pre-class activities, I have put the pages on which you can find a little bit information on anaphylaxis, okay? And so you can, if you want, you can go through that little bit of reading, but the PowerPoint should be sufficient, okay? And you're gonna have to take notes as I'm talking, because some of the slides is just like points mentioned, and then you're just going to write a little description of that because there is not much reading in the book. But PowerPoint should be sufficient. There's a little bit pharmacology. Again, it's not much. It's easy to understand. It's just 2 drugs that we're going to do. It's a Benadryl and epinephrine that we're going to do under anaphylaxis. And I have posted the reading. It was like a 1-page reading or so in your book. But again, having said that, the PowerPoint for this pharmacology should be sufficient because there is not much extra given in the book, okay? So this is just like how you're going to prepare for this lecture, how you're going to read it. And so let's begin with our discussion. And also, I think I'm going to forget. I just want to say that when you email me, in case you don't get a response within 24 to 48 hours, please send me another email. Chances are that I have missed the email, which sometimes it happens because of multiple emails that we get in a day. And so if that happens, please send me a reminder, and so that you don't think that I'm just ignoring you or anything. I just wanted to mention that. All right. So first is our introduction. What is anaphylaxis? Can you see a little bit at least the alphabets that are written, the sentences that are written here? Okay, all right, perfect. And again, I'll change the theme later. So anaphylaxis, okay, I'm gonna speak then, and in the PowerPoint itself that is posted in Blackboard, on that you are able to see it clearly because it's totally different theme. In Collaborate, it messes up with that, but right now I cannot change it. So I'm gonna read it, okay? And it's just like a couple slides or so. It's not the whole PowerPoint. Okay, and I'm going to point out as well. And so anaphylaxis is a type 1 systemic hypersensitivity reaction. Okay, so what that means is, first of all, hypersensitivity. Sometimes we say like, oh, this person is hypersensitive to say emotional experiences, right? What that means is that some of the emotions that one person is able to handle, the other person is hypersensitive to those emotions, right? Similarly, here, the emotions is replaced by allergen like a food or something, right, which people are allergic to. So those food or some allergen, some people are able to handle it well. Their immune system does not act against it, but some of the people are hypersensitive. So that is like the word hypersensitive, hence hypersensitivity. It is type 1 reaction. It says a type 1 reaction. I'll talk a little bit about that. Systemic, you know that it moves pretty quickly from just affecting your skin to being affecting the systemic organs. Hypersensitivity is an altered immune response to an antigen that results in harm to the patient. Okay, it is an altered immune response to some antigen. It is a severe and potentially life-threatening. That is the main thing that I, right in the beginning, I just want to mention that anaphylaxis, it is life-threatening, okay? It is rapidly progressing. You see a hives or you see like redness on the skin, and 5 minutes later, you'll see that patients have dysrhythmia. That's how fast it progresses, okay? So pretty simple. Okay, so here in the first slide, I put it is a type 1 hypersensitivity reaction. So you'll see that under the module on immunity, exemplar B is hypersensitivity. So there was some confusion. Are we going to discuss all those types of hypersensitivity in this lecture? So I just want to mention that these 3 hypersensitivity we are not discussing today. Okay, we are not discussing in detail, and so you do not have to go through the reading of the whole hypersensitivity exemplar. This will come at some point during next year under some of the diseases that you're going to learn. Okay, and so don't spend much time on that, because the chances are, if we haven't discussed it, all of that is not going to make sense to you. Okay, and so all you can read is type 1 hypersensitivity reaction, which again is there under the pre-class activities. So anaphylaxis is type 1 hypersensitivity reaction. There is 4 types of hypersensitivity reactions as mentioned here. It depends on the mechanism of action of the hypersensitivity, how the immune system is responding to the allergen. That's how these 4 types of hypersensitivity reactions are divided. Okay, and so our point of interest is in type 1, because anaphylaxis is a type 1 hypersensitivity reaction. Okay, and so you have to be very clear about that. Type 1 is anaphylaxis. Okay, so this is the antibody that is formed in response to the allergen is IgE. And by now, you should have a clear concept of what allergen is, right? So what is an allergen? Can anybody tell me? I hope I'm pronouncing it right, allergen. something that causes a reaction, provokes an immune response. There you go, right? It is pollen, for example, pollen. For example, people are allergic to peanuts, then peanut would be an allergen, right? It causes an allergen. There you go, right? Allergen. So something that we either ingest, something that touches our skin, something that is injected into our body, and so that will be an allergen, that our immune system that is responding to that. Absolutely. So allergen, how immune system mostly respond is by making antibodies, right? Antibodies to that allergen. So type 1 hypersensitivity reaction, our immune system form these type of antibodies, IgE. If the antibodies are divided on the composition, the chains that they have, the chemical composition. So IgE antibodies are formed in type 1 hypersensitivity reaction. In type 2, IgG and IgM are formed. Again, these three types of reaction, you do not have to remember this, okay? But this is just to let you know that there are different types of hypersensitivity reaction. Type 3, the immune complexes are formed. And type 4 is cell mediated. There is no antibodies in that. It is really the cells of the immune system that gets activated against the allergen. For example, phagocytes, they produce cytokines, okay? And also the time, type 1 is pretty rapidly progressing. As I mentioned, anaphylaxis within 1 hour, few minutes, it starts, and then within 1 hour, we see all type of different type 1 hypersensitivity reaction. They get full-blown allergic reaction. For example, anaphylaxis. This take hour to days. Hemolytic anemia is example. 1 to 3 weeks. Serum sickness and SLE, systemic lupus erythematosus, and days to weeks for the fourth type, rash and Sjogren disease. And but type 1 is IgE mediated. All you have to remember from this slide is that type 1 is mediated by IgE antibiotics within 1 hour of full-blown allergic reaction, and the example is anaphylaxis. Next, let's discuss the pathophysiology. This image may seem a little intimidating, but it's from your book. And once you see it, it's very easy to understand then. So what happens is this is your allergen. This is allergen. For example, a particle from the peanut, any antibiotic that people are allergic to, a pollen, as Sonia mentioned, a pollen, right? And so this is antigens, right? These antigen. And this is the body's cell, any cell on the skin, in the blood vessels, cutaneous tissue, in the organs. This is a cell. So antigen comes, it goes inside, it attacks the cell, okay? And the cell forms antibodies. These are the antibodies, these white color things, these are the antibodies, okay? And it says here, antibody, IgE. So antibodies are formed in response to the antigen, okay? And what happens is, because of the formation of antibodies, the histamine is released, histamine. And this you really have to remember from this lecture, that histamines is the main chemicals that are secreted from our cells in response to the allergen. And these are the main culprit who causes an allergic reaction, okay? Histamines cause are the chemicals that cause the allergic reaction for whatever happens in anaphylaxis. These are the main chemicals that are responsible, okay? Histamine. So antigen comes here, and then in the cell, antibodies are produced, and then this histamine green color chemicals are released, which causes, what does this cause? It causes here outpouring of the fluid from capillaries. So what does histamines do? These dilate our capillaries, okay? That's how we get the systemic reactions from allergen. It dilates the capillaries. It increases the permeability of the capillaries. So more of the blood or the serum from the capillaries is going to start moving out of the capillaries into the interstitial space, okay, into the connective tissue, soft tissue. And it causes release of mucus, and it also, histamine causes the constriction of the respiratory passages, constriction of respiratory passages, okay? And so this is really the pathophysiology. The whole image is the pathophysiology, pretty simple to understand once you get a good grasp on that. Allergen attacks the cell produces antibodies, it releases histamine chemical, the histamine goes to the capillaries, increase its permeability, more of the blood or the serum, it starts to move out, it increases the release of mucus and also causes the constriction of the respiratory passage. And here on the left side, what it says is a sensitization state. What that is, a sensitization state. So we, most of the times, that we need the people who are allergic to, say, pollen, they need the attack by the pollen 2 times. The first time, there is no anaphylactic reaction. The first time when they are exposed to pollen, say they are, they are little kids, they go out and it's the first time their body has seen pollen. So in that, when it gets attacked by pollen, the cells will produce the antibodies, but there will not be a reaction, okay? But they are sensitized now. There is already antibodies to that. And the second time when they get exposed to pollen, that is the time when it's going to be a full-blown reaction. Histamines are released, almost like a vaccine. There you go. And so most of the times it is true, okay? I'm going to talk about some exceptions as well. So sensitization is that first time there will not be a full-blown reaction, but there will be production of antibodies. The second time we are exposed, that is the problem, okay? And subsequent secondary responses. And here it tells everything. When it invades again, histamines are released, and they cause the capillary permeability. They cause increased mucus release. They cause increased constriction of the bronchioles, okay? And that's how it's going to cause wheezing, people having trouble breathing, and the airway constriction, that sort of stuff, okay? So this is sensitization state, okay? And so the exception to that is that sometimes people will see that they get, say, vancomycin, right? It's a penicillin, say penicillin, let's keep it simple. They get penicillin antibiotic, they have never received it. You're swollen and can't breathe. Yes, absolutely. And so this is first time that they have received penicillin. As Sonia mentioned, sometimes people get bit by snake, right? They have never been exposed to that poison. This is first time, but still there is a full-blown anaphylactic reaction, right? So why does that happen? There is no sensitization, right? The body doesn't know that allergen. For example, this little picture that shows the weight, you look familiar, right? So sometimes it does look familiar, but sometimes it doesn't. So the anaphylactic reaction that we just talked about needs sensitization and type 1 hypersensitivity reaction. But sometimes there is anaphylactoid, not anaphylactic, it's anaphylactoid reaction. So the difference in that is that it does not need the antibodies, IgE antibodies, okay? The allergen attacks the body for the very first time, but still there is a full-blown chemical reaction because it does not need antibodies. The cells of the immune system directly attacks the allergen. No antibodies are released. The cells attack the allergen, still histamines are released, cytokines are released, other chemicals, and it causes a full-blown reaction, okay? So you have to be mindful that even if people haven't received the antibiotic in the past and they say, I should be fine, still there can be a reaction, okay? Yeah, so this is a difference between anaphylactic and anaphylactoid reaction. Common allergens there. And so as you have mentioned before, some of the food items or the pollen, these are the common allergen. Having said that, anything out there really can cause allergies, right? Medications, I have listed here the really the medications. I wanted to write medications here. The vaccines, antibiotic, contrast dye, NSAIDs, opioids, these can cause allergies. Having said that, 100% of the medications out there can cause allergies. Literally, the Benadryl that we give for allergies can cause allergy. Okay? So you have to be very mindful about that in your clinical practice. That even Benadryl, Tylenol, anything can cause a hypersensitivity reaction, anaphylactic reaction. But these are the common ones I listed here that we see often in there. Yeah, allergic to can you be, that's a good question. I am pretty sure you can be allergic, because if you can be allergic to Benadryl, which we often give for the antibiotic for the allergies, right? And you can be allergic to epinephrine too. I really have to check some data before saying that, but I'm pretty sure anything out there can cause allergies. Okay, yeah, naturally, it is naturally produced by epinephrine, right? Epinephrine, good point, Ryan. Epinephrine, right? It is produced by which gland from your anatomy physiology? Adrenal gland, right? Yeah, the name itself, that's how you're going to make connection. Epinephrine, nephrine is kidneys, epi above the kidneys, a little triangle shape that is Anna is already saying she is. So above the kidneys there's a little adrenal gland that makes epinephrine. All the substances that are produced by our body, even those can cause reactions, right? Why? The amount is different now. That is what's produced by your body, but now we are injecting something more into the body. For example, the biochemical agents that we talked about in last lecture, those are kind of produced by your cells. Those are cell proteins, but still people can be allergic to that. And so the food that can cause allergy, common food is eggs, seafood, nuts, grain, beans, cottonseed oil, chocolate. Some of the pollen can cause it. Occupational agents are there. I talked about the medication, not really antibiotics. It should be medication. Insects and exercise. Sometimes there is exercise-induced anaphylactic reaction as well, that people are exercising more and there is a stress response that gets started in the body, and so it causes the same type of reaction that we see in anaphylaxis. Okay, yeah, this is called exercise induced anaphylactic reaction.
Yeah, my mother-in-law actually has this, and she can eat pasta, she can eat bread, she can eat things like that. But if she exercises at all after she has any kind of wheat or gluten or anything like that, she has like a
Yeah.
major anaphylactic response. It's wild.
Wow, wow. So that is something, that's where our, keen assessment, observation, because our family members, okay, we know it's only one person there. We are doing good assessment. We are taking them to doctor. And so in the clinical practice, that's where our job comes to see that what type of anaphylaxis is happening, what is the allergen, referring them. So that was a very good example. Thanks for sharing, Ryan. So this is called an exercise-induced anaphylactic reaction. And now signs, symptoms. Now this is very important, okay? I want you to remember the signs and symptoms of anaphylaxis. So anaphylaxis, as any other type of hypersensitivity reaction, it starts pretty much at the skin level, okay? At the skin level. If we really are competent and we are keen observers and we do good assessment, we can catch that anaphylaxis reaction very soon. This is the reason why we stay in the patient's room for first initial 15 minutes when we administer blood to them. When we administer blood, even if they have gotten it before multiple times, still they can have reaction. But that's not anaphylaxis. It's a different type of hypersensitivity reaction. Just to give you an example, we can catch it very early if we are keen observer. Little something, the itching they have on the skin, little redness here and there. Now we have to be mindful that within 5 minutes or so, it can really cause dysrhythmias, depending on the patient, comorbidities, age, and everything. So all these symptoms on the left side, these are cutaneous symptoms of anaphylaxis. Also hives and itching. Sorry, this should be on this side, okay? Hives and itching. But as the allergen goes into the body, mostly the cutaneous cells, the dermis, the epidermis, those are our first line of defense in the body. The skin is the biggest organ in the body, right? If we start rolling the skin, it's going to be a big football, right? And that's the big thing. So it's a first line of defense in the body. It will cause itching. Hives is the red spots, little red spots. Flushing of the skin. Flushing is, now it's more blood is going through the skin, it's getting redder, right? Like kind of on the red side, redness. And angioedema, as I mentioned earlier, the histamine, which is the chemical responsible for anaphylactic reaction, that increases permeability of capillaries, that causes a dilation of capillaries, okay? So that's basically angioedema. So we will see the swelling happening, skin getting more red because of angioedema. Urticaria, this is again the itching on the skin, the redness, the same skin cutaneous reactions. Erythema, hives and itching, again, it's the same thing. So this is the reaction. This is the first reaction. Again, early signs, right? So the perfect question that can be asked, the early signs, the later signs, as you got in previous exams as well, and you did pretty well on that. And the systemic signs and symptoms will be these ones, right? These ones. So what happens is inflammation of the airways. So if you are clear about the pathophysiology, these symptoms come naturally, that it dilates the capillaries and it constricts the bronchioles. That's what histamines are doing. So what it's going to do, inflammation of the airway because of dilation of capillaries, wheezing because of constriction of bronchioles, abnormal heart rhythm, dysrhythmia, because the blood volume is low, the cardiac output is low. It's going to cause eventually dysrhythmias, low blood pressure. Again, the same concept. Weakness, lightheadedness, dizziness, nausea, vomiting, diarrhea. It's because of the now decreased blood supply to the to the organs, to the digestive system. So you're going to have these symptoms: cyanosis, hives, and itching. Okay, these are pretty self-explanatory symptoms of anaphylaxis. Once you have good hold on the pathophysiology, what is actually happening there? Now, what is the difference between anaphylaxis and anaphylactic shock? You should have a good idea about it. You had lecture on hypovolemic shock. What is the difference between anaphylaxis? You can unmute yourself as well. Anaphylaxis and anaphylactic shock. Shock, you can die. Okay, that's a good way to put it. Yeah, one good way. What else? We say anaphylaxis is happening. We say anaphylactic shock. There you go. Yeah, I'm sure many of you know about that. It's just sometimes hard to put it into words, but it's really a later stage of anaphylaxis. For example, hypovolemia, right? You had a great lecture on perfusion is decreased. Absolutely. You had a great lecture on hypovolemic shock. And so hypovolemia is first, and then you go into the shock. And what are some of the other types of shock? One is hypovolemic, one is anaphylactic, and the third one that we have discussed, septic shock. There you go. Hemorrhagic as well, but septic shock, because we discussed that in the infection, right? So now you can see that all of these different things that are happening in the body, they ultimately lead to the same response at the end, right? Body gives up. It's not compensating, as you learned. It is not compensating, it just gives up. So basically here, anaphylaxis happened, and now the body has just given up, that I cannot do it. For example, the neurological first symptoms, the restlessness, anxiety, lethargy, confusion. Cardiovascular, in shock, there will be tachycardia. Still, I think body is a little bit trying to compensate. Thready pulse. Thready pulses, now the pulses feel like a tiny thin thread, right? When you put on it, it's not really a good +2 pulse, but it's like tiny thread, it feels like. Low cardiac output, low blood pressure. Okay, this is, and eventually in shock, even the tachycardia is gonna become bradycardia, because at this point, really, the body is trying to compensate by increasing the heart rate to 120, 150, 180. But as the blood pressure goes lower and lower and lower, and then even the pulse will become 50, 40, 30. Now you know that patient is going to go into cardiac arrest if we don't do anything, okay? And pale, cool, clammy skin. Why does that happen? Pale, cool, clammy skin. From our concept, see, these concepts are interrelated. From our concept of hypothermia. Can anybody tell me why does that happen? Blood to the organs. Okay, thank you. Yeah, great job. So the blood from the peripheries that Is my voice clear? One of the students put that my voice is breaking up. Is everybody else able to hear? Well,
Yes.
okay. All right. Thank you. And so this is good, right? It is moving to the organs. So that's why pale, cool, clammy skin, rapid breathing, shallow breathing, compensation, right? And low temperature, thirst, acidosis. Acidosis will happen. You have learned in hypovolemia that an anaerobic respiration will start, lactic acid will be produced, less oxygen to tissues, acidosis will happen, low urine output. So basically, if an anaphylaxis we don't treat, it will move to anaphylactic shock. That's the only difference between these two. Risk factors, again, not many risk factors, but if you have previous anaphylactic shock, obviously you are more at risk factor. You have you have seasonal allergies, or you have asthma, which is again allergic reaction, then you are more at risk factor. Atopic diseases are some of the diseases and disorders that occur because of your genetic predisposition to allergies. Okay, genetically, your parents have that, your siblings, your grandparents have that. You are at more genetically predisposed to allergies or to anaphylaxis. So just 3 risk factors really. Diagnosis is simple as well. Not too much detail here. Mostly it is done by the symptoms. Obviously, if we see anaphylactic reaction once, we will know that second time, okay, this is what I am looking for. This exactly is anaphylaxis. You will see the skin reactions, you'll see the wheezing, you'll see the airway constricting, and all the symptoms and of shock later stages as well. So mostly done by symptoms, but sometimes people just don't know which allergen is causing this reaction, which many a times actually it happens. And for that, there is a skin testing that can be done. What they do is, it's a pretty simple thing to understand that they take, say, these 40 common allergens. They, with a tiny needle on your arm or on your back, they inject all those allergens, right? At a little bit width, they inject the allergens, and they mark it, and they put maybe A, B, C, D, E, or whatever, and they write it on the paper that, okay, this is the A allergen, this is the B allergen, this is the C allergen, say pollens or antibiotic or something, and they see where it's causing the cutaneous reaction. As simple as that. Okay, this is the skin test for allergy, and the blood test for allergy is, again, very simple. They take a sample of blood, which has serum and all the blood cells in it, and they react it with the different type of allergens. And what is going to be produced? What are we looking for? What is going to be produced in that blood or the serum? Antibodies, right? Antibody IgE, and then histamines, right? So we are basically looking for the antibodies to be produced. So these are the basically 3 very simple diagnostic tests for anaphylaxis. Prevention is the key. Prevention is the key for anaphylaxis. So best way is avoid the antigen. That's it. Best way is avoid the antigen, right? Once it gets started, the allergic reaction, it's really the whole management thing that you have to do, right? And we are seeing it more and more now. These allergies, as you will notice that in the give extremely low dose of allergen, minimize your, okay, thank you for sharing. Alyssa said that they give you, absolutely, they give you that sensitization as well. And so that you don't don't respond like full-blown reaction, they might give you minimal dose of allergen, and just like vaccines. And so you will see that in your clinical rotation, you have seen patients have multiple allergies, right? When it says no known drug allergies and no known medication allergies, that's or food allergies, that's kind of rare to see nowadays for some reason, right? Earlier, years ago, it did not used to be that case. Now, multiple food, multiple drug allergies. So as nurses, we have to be very mindful about that we keep them away from those, right? Sometimes people will have simple food allergies like eggs, right? Now it's our job that we educate them. We call the kitchen not to send them. We have to be very mindful in the room, they don't share it with each other and something like that. And So best ways to prevent. The second is they should always wear a medical alert necklace or bracelet, right? Keep an emergency kit, which I will talk in detail about the which kit we need, and meal slips as well. It definitely, and in the meal slip it says they are allergic to that, but we just have to make sure the trays are not intermixed, which sometimes in the rehab centers it happens if we are not mindful. So we always have to make sure we tell you the name and the ID band, and so very careful. Be sure to alert all your providers. And if you're allergic to the insects, stay away from that. Food allergies, carefully read the label. So prevention is the key, very simple preventive measures that you have to follow. This is a little form I wanted to show you by American Academy of Allergy, Asthma, and Immunology. They are doing a lot of work in this preventive measures. So this is something that a form that they can fill with the doctor, that okay, these are the symptoms that I get when I have allergies, and this is my action plan. What I'm gonna do, I'm gonna do the epinephrine injection, EpiPen, which I will talk about it, and these are my emergency contacts. So this is a form that they fill along with the provider to come up with an action plan in case they have anaphylactic reaction. And there is a little cards as well that they can put in the wallet, then they can put in the purses, and that has all that like allergies listed and what type of symptoms they have. Everybody's going to have different type of reactions, and what is their emergency contact number. So these are very simple things actually that we should educate the patient on, right? And especially in the kids in schools, we see this a lot. Okay, I want to spend a little time on that because this is very important. And if you have to take some notes here and there, you can take that as well, okay? Because this is your interventions. What you're going to do. You have heard about that a lot. Now, I wanted to reinforce the point because this is not just in anaphylaxis. This is true for your surgical patient. This is true for your medical patient. This is true for patient going into cardiac arrest. This is true when you're calling rapid responses, okay? This is true for your general assessment. You walk into the patient's room, right? Before you head to do assessment, you really have to make sure they're breathing, their airway is okay. So get into the habit of this. If you just train and educate your mind to work in this ABCDE thingy, and your assessment skills are going to be much way better. Okay, so when you walk into the patient's room, you say, hello, my name is Aisha, I'm your nurse for the day, right? How are you doing? Okay, patient says my name is this and this, so airway is good, right? You're not worried about it. So now specifically in anaphylaxis, all it is saying that if you see a cutaneous reaction, don't just jump in to call the provider, don't just jump in to get the vital signs. Just make sure first their airway is okay right now. They are not like literally choking and their airway is constricted in anaphylaxis, okay? And if we just talk about that, so airway, first thing is airway, and these are very concrete questions that you have to ask yourself for the airway, okay? This is a very good actually picture that you can follow, and these are the management. What are you gonna do to maintain airway? Some of this you already know. Some of these you will learn in next semester. For example, airway adjuncts. These are the last thing, airway adjuncts. For example, laryngoscope, the tracheostomy. There's a little tube that you can put and rotate, and that just maintains the airway. So you'll learn about that. But you can do suctioning. You can do head, back, and chin lift, and you can do some maneuvers, Heimlich maneuver, but these are the things you can do for suctioning for airway, okay? Second thing is, even for post-surgical patients, second thing is breathing, okay? So breathing, how you're gonna check is chest symmetry, the respiratory rate, the pulse oximetry that comes after you're done with the airway, okay? Patient is having reaction, check their breathing. Breathing is a problem, you do these things, okay? And the C is circulation. So circulation, how you're going to check is really do not move to like capillary refill time as much as you would think that, okay, circulate. The first thing for circulation is check their heart rate, check their blood pressure. In emergency, really capillary refill time, you can do that. It doesn't solve your purpose. If their heart rate is low, if their blood pressure is low, you have to do something, okay? And so main thing is really manual pulse and blood pressure, okay, and patient positioning. Okay, circulation actually management is IV fluids really more than positioning is good too. That's the first thing you will do. The fourth thing is disability. Okay, you have heard of this as well. Disability is basically your neurological status. Okay, neurological. Now, after airway breathing circulation is done, then you move to the neurological right away. Don't get forced to see their pain level. We are not worried about it at this point, right? If their the pulse rate is 30, why do you want to check their alertness, whether they're alert or not? You're not worried about it. If their heart rate is now 80, their blood pressure is 180, 120 by 80, then now, okay, you know, I want to check the alertness. And so AVPU, if you want to write it, this is again checking their alertness. Pretty simple to follow. First is alert, second is verbal response, third is pain response, and fourth is unresponsive. So if you want to check their, if you want to check their how alert they are, so first is they're completely alert. Verbal responses that you call them and then they respond to you. Then pain is they are not responding to you. You put some pressure, put some pain, pinch them, and that's how they respond to you. And U is unresponsive. Okay. Then you check under this temperature, blood sugar, fast. So fast is really for stroke. Okay, but it falls under disability, not really in anaphylaxis, we won't do it, but it's specifically for stroke. In anaphylaxis, we will check their alertness, temperature, blood sugar, pupils, and pain, okay? Anybody knows the FAST acronym for stroke, which is so very important. Even if you haven't had the lecture on it, in community, there is just so much awareness they are spreading for stroke. Okay, F is facial drooping. A, what is A? Very good, Renee. Facial drooping, arm weakness. There you go. S. Speech difference. Yes, absolutely. Speech garbled. Okay. I think, garbled speeches, you cannot understand anything, right? This is garbled speech. You can't understand. Incoherent. Okay. And T. What is T? Is time. Time is everything. Okay. In stroke. Very good. Just wanted to touch base on that. But in anaphylaxis, you know that's it. But if there's a little confusion, that's why they put it there. And but facial droop, arm weakness, one side is you cannot miss it really. As a healthcare personnel, if somebody is having stroke, you cannot miss it, right? And time is key because of the medications that can be given. Exposure. Then the fifth thing is exposure. Then you expose, head to toe assessment. You check the lungs. You check the nausea, vomiting, anything that you want to do and manage it. Okay. A, B, C, D, E. Very, very, very important. For your clinical, for exam, for questions, and just educate your mind to work in this ABCDE fashion, just to get competent. Nursing interventions, sorry, again, this slide isn't. So the nursing interventions, it is not in sequence, guys, but for anaphylaxis, just to give you a little mnemonic, just to give you, somebody I think unmuted, do you have any question? If not, you can mute yourself. Okay. And so the mnemonic is act fast. Okay. Just to help you remember what you're going to do. The first is A is allergen. Remove the allergen. If you can please unmute yourself, that would be great because there is a lot of distress. Thank you so much. And the first is allergen, remove the allergen. The second is C, act, C, call rapid response. If you see anaphylactic reaction in the hospital, you should call rapid response. You're not going to be able to manage it by yourself, right? Trendelenburg position because of the shock. F is first line drug is epinephrine. A, administer other drugs, which I will talk about. Stay with the patient because there can be another. Even if you manage one anaphylactic reaction with EpiPen or something, there can be another reaction, maybe 10 minutes after the first reaction, okay? So you have to stay with the patient once they have reaction. And just to make sure that there is not other reaction. This is like specifically for the hospital setting, acute care setting, and or rehab. And the last one is teach. You have to do a really good teaching after they have one allergic reaction, right? They are going to be able to manage it by themselves later on. So act fast. This is a little mnemonic, not in sequence, but what are your interventions that you can do for anaphylaxis? The pharmacology. Okay, now the pharmacology, we are only going to do 2 drugs. Okay, that's it. And the 4 classes of drugs that can be used for anaphylaxis is, first is non-selective adrenergic agonist. Agonist. Can you please strike antagonist? It's agonist. Sorry. Everybody, please be careful and strike the antagonist. It's agonist, non-selective adrenergic agonist. Okay. The first class of the drugs that we use, and the drug that falls under this category, anybody knows that? I think you have heard of that in shock, the lecture of shock, probably. Yeah, you did. Non-selective adrenergic agonist. It is also called vasopressor. Okay, dopamine. Yeah, it is also called the vasopressor. Very good, Sonia. And vasopressor, specifically for this that we're going to use for anaphylaxis. It can be used for shock, absolutely. For other type of shock, it is epinephrine. Epinephrine, thank you. Epinephrine, okay? Non-selective adrenergic agonist, epinephrine, and that is the drug we're gonna do. Antihistamine, it prevents release of histamine. Histamine is the main culprit. It prevents its release. And the drug under this that we're gonna do is Benadryl, okay? Benadryl. These are the 2 drugs that we're gonna do. And PowerPoint is sufficient because I did put all the prototype intervention information in the PowerPoint. And the 2 other drugs that can be used are bronchodilators and corticosteroid. Bronchodilators is simply iprovent and something to dilate sympathomimetics. But you will learn that later lecture. So we are now gonna elaborate on that, and corticosteroids to reduce inflammation. Okay. So let's do our first category, or first drug, which is epinephrine. Very, very important drug, okay? And you'll hear that in next semesters as well. And so this epinephrine, it is also called adrenaline. Adrenaline. Why? Because it acts on adrenergic receptors. Adrenergic receptors. There is 2 types of adrenergic receptors, alpha and beta. Alpha and beta, okay? And now from your anatomy physiology class or from your previous knowledge, if the adrenergic receptors, alpha, beta, are stimulated, which type of nervous system is activated? Which type of nervous system is stimulated? Adrenergic receptors, alpha, sympathetic. There you go. Very good. Good job. Sympathetic. Okay. Sympathetic. Now, I just want to mention that get a good hold on these sympathetic, parasympathetic nervous systems and how these get activated and what does it do. Because a lot of your drugs under pharmacology are going to be very simple. The questions are going to be very easy to answer if you have a good hold on that. What is their activity? For example, this epinephrine falls under different categories, is used for multiple purposes, okay? And similarly other drugs too. But epinephrine, it is also called adrenaline. It activates alpha and beta receptor. That's all it says here in action and uses. Alpha and beta receptor, alpha 1, alpha 2, beta 1, beta 2. There's basically 4 types of receptors. When beta 2 receptors are activated, okay, it is an agonist. When it is activated, then it causes a dilation of the bronchioles. So our symptoms of anaphylaxis, of the wheezing, of the the breathing issues, whatever is happening, that will get relieved because of its activation of the beta receptors. And it also activates alpha receptors. When anything activates alpha receptors, what it causes is it constricts the capillaries, constrict the vessels that has been dilated by histamine in the during the anaphylactic reaction, right? So now this drug, what it's doing is it's stimulating alpha receptors. So it is causing now constriction of vessels. That's what we want, right? We want our blood pressure to be raised. We want our heart rate to be raised. We want more cardiac output now, right? Because everything is going into shock. And so it solves the purpose, right? So it is even a drug that is given in cardiac arrest. People whose heart gets stopped, we give this drug, okay? Because of its use. And it is also called non-selective non-selective adrenergic agonist. Why? Because it does not act on just alpha or just beta. It acts on both of these, and that's why it's non-selective. Okay, that is all the information it says. And here I just want to inform you that intracardiac route is when you're shooting directly into the heart. You have epinephrine with you. There is no like vessel you can find, and so now you directly shoot it, but it's really done. Can be done though. It just directly goes into atrium or ventricle, and that's how it's given, because it's a life-saving drug. So it is an irritant if it is given through the IV route. It is irritant, so we have to be mindful about that. Pregnancy category C drug. There is different pregnancy categories, A, B, C, D, E, and I think Z. C is that the provider has to weigh the risks and benefits really, and it acts pretty fast, as you can imagine. These are the adverse effects of epinephrine. Again, if you have a good hold on pathophysiology and how this works, you will know that it may cause tachycardia, okay, hypertension. It does not mention, oh, it is mentioned, hypertension, okay, it can cause palpitation, tremor, restlessness, nervousness, and headache, stinging, burning at the epigastrium. So very simple adverse effect. And if you can make a little, flashcards or something, that will be very helpful for you for learning pharmacology. These are the contraindications when it cannot be given. But again, it's a life-saving drug only given in emergencies. There is not really contraindication. If they say, if it affects the kidneys, I'm just making it up. If it affects the kidneys, what's more important, saving the person's life or kidneys? I mean, there's not no contraindication. Some of the cautions are, these, like, for example, dysrhythmia, cerebrovascular sufficiency, hyperthyroidism, narrow angle glaucoma. Because why? It worsens the symptoms of these things. Having said that, it is not an absolute contraindication. It is a relative contraindication in which we have to be just cautious about it, okay? And because of the constriction, glaucoma, hypertension, ischemia, and all this. So epinephrine is, these are some of the interactions with other drugs, okay, lab test. This is an important concept as well, okay? You must remember that epinephrine, because of its effect on sodium-potassium pump, important thing to remember, that it decreases the level of potassium. It decreases the level of potassium, okay? So epinephrine, you are going to make sure that you do the blood work for potassium, especially if the potassium level is low because of the comorbidities, and it increases the sugar level, okay, glucose level. So this is something important. And EpiPen. So the EpiPen, how it works is we give EpiPens to people who are already like prone to allergy, anaphylactic reaction. The main thing is blue to the sky. It has two ports, a blue and the orange one. Blue to the sky, orange to the thigh. Okay, little mnemonic is. So what they do is, it is a quick dose of epinephrine. Always they should carry it with them. It is given in mid thigh, and they do not have to take the clothes off for giving that. Okay, they can just give it over the clothes. Even if they give it and they are okay, they still have to call 911 after injecting. Why? Because there can be a biphasic reaction, another reaction after that. Expiration date, they have to be mindful and teach the family members as well. Okay, so very important EpiPen teaching, very, very important. Okay, so you must remember that. That's little mnemonic, how it's given, what are your responsibilities. Antihistamines. This is a Benadryl, pretty simple drug. It blocks the action of histamine, okay, which is the main culprit, I said. So how it blocks is, it is a H1 receptor antagonist, okay? That's how it blocks the histamine chemical from releasing. And it is a first generation antagonist. It can be gotten over the counter, and the intramuscular IV routes are available. Some of the other uses are, it can be used in Parkinson's disease, motion sickness, and insomnia. Okay, these are some of the other uses because of its action on neurological system. Administration and alert. Another important thing to remember for you is that Benadryl can cause shock. Why it can increase the risk for the shock? What are your thoughts about Benadryl? In general, actually, why does it increase the risk for shock? If it doesn't work, Uh-huh. What else? What are your other thoughts? Anything? Benadryl. Drowsy, slow. Drowsy, slow. Actually, these are sedative. There you go. CNS depressant, basically, right? CNS. This drug is a CNS depressant. Anything that is CNS depressant can cause shock. Okay, it can lower the respiration, and lower the heart rate, lower the blood pressure. It can cause shock. So it can. We have to be very mindful when we give it. It's really for like mild allergic reaction, as you can see. The full-blown anaphylactic reaction, it's not going to do much. Okay, but we just have to include the pharmacology for maybe cutaneous purpose, cutaneous reaction. Um, these are some of the side effects of Benadryl. Some of these are, related to the mechanism of action. This dry mouth tachycardia, mild hypertension, it is because of its anticholinergic properties, okay? Because it affects the cholinergic system to not release acetylcholine. But these are some of the side effects. Again, you have to make little flashcard for you to memorize. This is something to memorize, right? Really, like, and these are the contraindications for Benadryl and some of the interactions with CNS depressants and MAO inhibitors. MAO inhibitors, MAOI, you're going to learn about in psychiatry, but MAO inhibitors, they also have property in which they increase the heart rate and constrict the vessels, the sympathomimetic, sympathetic system, it activates. So really a lot of drug interaction you will see with this drug, okay? So this interacts as well. So that's all, not a big topic, that's all I have. And now I will open the session for question. And first, let me just very quickly read you this one thought. I was saving this thought for my last lecture, because this is my last lecture with you guys for the semester. And next semester, as you know, you have new faculty members. But you have heard me a lot talking about assessment, and I know I'm gonna miss you guys. Yeah, and so I have talked a lot about assessment and observation. Okay, and this is a very very straightforward thought quote that's written by Florence Nightingale. But really, you have to carry this thought forever throughout your career with you. Okay, and just this one thought I'm going to share with you. For it may be safely said, not that the habit of ready and correct observation will by itself make us useful nurses, but without it, we shall be useless with all our devotion. Okay. She says the skill of observation and assessment, which is your interview, observation, physical assessment, diagnostic test, I have talked about it. So she says, maybe by itself you think that, okay, it's not going to save the patient just by observing the patient. Okay. Obviously, you have to do some intervention, you have to call the provider. But she says, if you don't have this skill, no matter how compassionate you are, we as nurses are useless. Can't be more straight than that. Okay, we as nurses are useless no matter how compassionate we are if we are not able to observe and assess the patient. Okay, and she says, but if you cannot get the habit of observation one way or the other, you had better give up being a nurse, for it is not your calling, however kind and anxious you may be. Okay, very straightforward. I just wanted to, because now you have done 2 semesters, you have pretty good hold on what nursing is and how, you what skills you need. So she says, if you cannot observe and assess, right, no matter how kind you are, no matter how anxious you are, we won't be able to do anything much for the patient. Okay, so this is one thought I wanted to share with you guys. And having said that, and first of all, I want to open the session for questions, guys. And if you have any questions, please, you can ask me now. And again, I'm available. You can email me, you can set up a session or something. Thank you. And yeah, and as I will see some of you during exams and, in clinical and lab and everything. And but wish you good luck. Okay, I just want to wish you very, very good luck for your exams, for graduation, for your licensure, for your career. It was an absolute pleasure to to be with you guys. And yeah, thank you so much. Thank you for giving me the opportunity actually to share knowledge and expertise. Thank you so much, guys. I will definitely miss you guys. You guys were my first batch of students as a full-time faculty. So it will be a pleasure to see you guys graduating, definitely. Mhm. Thank you, guys. Thank you. It just means so much. Your love and everything that you give, it's yeah, it means a lot. But again, even if I'm not there next semester, please feel free to reach out to me. Okay, I still will be in Nagatak and all the other faculty member. Please feel free to reach